There have been several clinical trials designed over the past couple of years looking at novel combinations with ibrutinib. Ibrutinib rituximab, ibrutinib Revlimid rituximab, ibrutinib venetoclax, ibrutinib rituximab followed by high-dose chemotherapy, and so on. And I think at best what I can say is the data is largely preliminary. I think right now there's a lot of interest in understanding how the ibrutinib venetoclax approach will fare out in a randomized trial, and I suspect it will improve PFS. The big question is by how much and for what subgroups of patients. Are we going to be really addressing the non-canonical and FKB mutations in mantle cell lymphoma, as was observed, by the way, by Dr. Tam's group? It seemed like that as a risk factor was less important when we brought in the venetoclax. But are there other subgroups of patients that we're going to benefit that otherwise would have seen worse outcomes? Only time will tell.
Regarding the question of ibrutinib frontline therapy, I am optimistic about seeing at some point ibrutinib becoming the backbone of the treatment for all patients with mantle cell lymphoma. We are going to get there. So we are seeing the impact again. In chronic lymphocytic leukemia, we are all excited about presentations in this ASH meeting about ibrutinib being better than chemoimmunotherapy that we currently have for CLL frontline. Are we going to see the same in mantle cell lymphoma? I am very hopeful that that is going to be, but the clinical trial needs to show that. And there is a clinical trial that was completed to accrual, ibrutinib plus bendamustine rituximab versus bendamustine rituximab. That has been completed, so we are waiting for the data to be presented or published. There is interest also in combining ibrutinib with other chemoimmunotherapy as a frontline. But to me, one of the most excited combination that we're going to see in mantle cell lymphoma is the combination of ibrutinib with a BCL2 inhibitor, venetoclax. Significant activity in relapse setting, ibrutinib venetoclax. As we move into the frontline setting for patients with de novo mantle cell lymphoma, so we might see a second major change in the landscape of how we treat mantle cell lymphoma. There is going to be a role in terms of combination and frontline therapy, so we are awaiting the data of a clinical trial in which ibrutinib was added to bendamustine rituximab versus bendamustine rituximab alone. So we are waiting for that. And also, I think there is interest to know what will be the value of adding ibrutinib to R-CHOP in mantle cell lymphoma. We are disappointed that that combination, although it's a different disease, that combination didn't work well in large cell lymphoma. Ibrutinib plus R-CHOP didn't add much. Is that going to be the case in mantle cell lymphoma? Remains to be seen.
What I'm looking at is more data regarding the combination of ibrutinib and venetoclax, or the sequencing of those drugs, with or without a CD20-directed antibody. There's been reports that MRD can be achieved with that combination, and that may allow us to have limited amounts of therapy, which is really the downside, I guess, of having the current therapies, is that at the present time they're continuous.